agent.
Thank you
You
very
have
much.
25 minutes here.
Thank you very much, Dr. Ahmed. This is a very nice introduction. I'd like also to express my gratitude to the organizers, both SSBMT and also SSH. Actually, my presentation will not be only Luspatercept, but also what's behind Luspatercept. So just be ready for some new information. But I have to start with some basic background. So these are my outlines. As you can see, I'm going to talk briefly about pathophysiology, current medication, the management, as well as the Luspatercept mechanism, as well as the clinical evidence. Then I'll move to the novel and cellular therapy and what is the future directions that will be in the coming few years. So we've been taught when we were in medical school that these are the typical clinical features for sickle cell, for thalassemia, and this should not happen. We should not see it anymore. The mongoloid features, the frontal bossing, or the depression of the nasal bridge, or what's called the chipmunk facies. If this happens, this means that the patient is not well managed or he is not compliant to his treatment. So we know this may happen in certain areas, but this should not happen and should be a history, medical history, not anymore. So we know that thalassemia is basically a spectrum. It's not only one disease. So some patients may have no symptoms, so they are trait, and we have some patients who they have mild to moderate symptoms. They may require transfusion, so they are non-transfusion dependent thalassemia. And some patients, they are really hooked on transfusion, where they will be on transfusion to survive, and that's basically the transfusion dependent thalassemia. And these two groups, the non-transfusion dependent thalassemia and transfusion dependent thalassemia, we have guidelines for them from the TEF, the Thalassemia International Federation, so we are following these guidelines. And when we talk about the erythropoiesis, normally there are a lot of cytokines, the transcription factors, including erythropoietin, where this really maturation of the erythroid precursors are not always happening in patients with thalassemia. So basically, to understand it very well, normally we will have the two stages of the maturation. So the first stage is the proliferation, and the second stage is the maturation or the differentiation of the erythroid precursor. So that's the later stage. In thalassemia patients, what we have is an expansion of the erythroid progenitor. So that will lead to more erythroid precursors, and because of there is already high erythropoietin, but the maturation is defected. That's why we'll have impaired erythroid maturation. So basically, erythropoietin is high, but again, TGF-beta superfamily ligand is high. That's why we'll not have a proper formation of the red blood cells, and therefore anemia. And here you can see in the left side where the normal patients, they have normal red blood cell production, while in the right side you have the increment or the enlargement of the erythroid expansion, where the product ultimately will be very low and there will be anemia, and in addition to the hemolysis there. So that will result into multiple symptoms due to the ineffective erythropoiesis, anemia, iron overload, abnormal bone marrow microenvironment, in addition to the hypercoagulability. So the outlines of the management, normally some patients, they may have splenectomy in order to tackle the anemia and ameliorate the symptoms, and that will be on the expenses of developing more hypercoagulable state. Some patients, they will require transfusion to tackle both the ineffective erythropoiesis and the anemia, but that again will pay the price for secondary iron overload that will necessitate to have iron chelation therapy and to treat both the secondary iron overload and the primary iron overload. And you can see here that we have multiple targeted points. It's a very complicated process, and to one lock that we will see multiple points that we need to look at. And some patients, we enrolled to JAK2 inhibitors, the gamma globin persistent, including hydroxyurea, the alpha alpha-globin mutation, and there are also some trials for the iron overload. But the most important part here is basically to look at these two here, the luspatercept and the pyruvate kinase receptor agonist imidabavats. So what is luspatercept? It is basically a first-in-class recombinant protein that binds to select TGF-beta superfamily ligands and inhibit the SMAD2 and 3 signaling and enhance the late stage of erythropoiesis. So basically, the luspatercept will come and inhibit TGF-beta superfamily ligand, will lead to the inhibition of the cascade down intracellular and removal of the inhibition on the erythroid maturation. So we are basically inhibiting the inhibition, so that will lead to stimulation of the erythroid production. And this drug is being already studied in 2 landmark clinical trials. The first one is the Believe It trial that was studied for patients with TDT, transfusion-dependent thalassemia, and the study was published in New England Journal of Medicine in 2020. And the second one is the Beyond trial, which is basically for patients who are non-TDT, and that was published in 2021. And looking at the Believe It trial, you can see that those patients enrolled were transfusion-dependent thalassemia, were randomized into 2-to-1. Luspatercept arm was 224 patients, and the placebo arm was 112, and they were allowed to go into the open label phase up to 5 years in order to see the outcome. And those patients basically looked at the blood transfusion burden reduction more than 33%. And you can see here that the primary endpoint was already achieved, and see that the patients who were on the luspatercept arm achieved more than 33% reduction in 21.4%, while it was 4.5% on the placebo arm. And if you look at the subgroup analysis, it was all of them, but more with patients who are splenectomized and those patients who were non-beta 0 group. And the side effects was acceptable. Most of these are headaches, arthralgia, back pain, and flu symptoms like. And that's not only for the blood transfusion, but also for the iron overload parameters, including serum ferritin and the MRI liver iron concentration. And that's why it was integrated in the management of the guidelines of the TIF guidelines. It is for those patients who are 18 years of age and above, so you can use luspatercept. On the Beyond trial, which is for the non-TDT patients, again, the patients were randomized into 2 groups and comparing them with the placebo arm. And basically, the endpoint was to have increment by 1 gram, at least by 1 gram. And that was achieved in 77.1% in patients who were in the luspatercept, while there was 0 in the placebo. And it was also evident in all subgroup analysis as well. And you can see here that 77.1% of the patient got 1 gram increment, and 52.1% got even more to 1.5 gram increment. And you can see some patients even they reached to 3 grams increment on luspatercept. Not only the hemoglobin, but also the quality of life, and that's reflected on the long-term follow-up on those patients. It was already integrated on the non-TDT guidelines from the TIF, and you can see here that any patient who are 18 years old and of age, they can be started on luspatercept. What about pediatric patients? This is only 18 years of age, but there are, in the last ASH, last December, we got some updates that they are using it for pediatric patients with promising results, but waiting to get more data to be approved to be used in pediatric patients. So this is not only for pediatric, but there are also ongoing clinical trial for the alpha thalassemia, and it estimated to be completed on July 2027. And hopefully you can be able to use it also for alpha thalassemia once the results are out. So what about cellular therapy? We know that there are a lot of the novel therapies, and thanks to Dr. Mohsen and Dr. Ihab for setting the stage for me to talk about the cellular therapy. We know that the curative therapies are basically either stem cell transplant or gene therapy in patients with thalassemia. And we know that the patients with thalassemia are between 2 options. The first option to go with blood transfusion and to treat the complication of the blood transfusion, iron chelation, and so on, or to take those patients to transplant early on, preferably below the age of 16, so that we will get the transplant earlier. Although there are complications like infectious complication, graft failure, or graft versus host disease, where we have to keep in mind that we do not really need to have this graft versus malignancy because this is a benign disease. What about if we do not have a donor? And many patients, they do not have donor for thalassemia patient. That's where the gene therapy comes in. And thalassemia was among the first genetic diseases that were proposed to get also gene therapy. And the advantages here are basically that we do not really need a matched donor. We do not really need to worry about graft versus host disease or graft rejection. And there was the clinical trials on genetic gene therapy. And we know that there are two approved medication gene therapy for thalassemia, the bit-Cell, which was approved in 2022, and it was the most expensive drug back then, and now the other therapies are coming, so maybe the prices will be less, and hopefully we'll get lower prices. So that's the bit-Cell, the Bluebird Bio company, the Zynteglo, and the other one is the Casgevy or the Exocel, and by Vertex, and this was approved in 2023, and thankfully we have this approved in Saudi Arabia, and that basically we are using it, and I have already one patient who came to me last week after gene therapy 1.5 years ago. The issue here is that whether to go with viral vector or CRISPR-Cas9 technology, the problem is that both of them, they will require busulfan myeloablation conditioning, and that's really bothering the patient to make them hesitant to go for gene therapy because of the side effects of this myeloablation. This has been already explained by both Dr. Ihab and Dr. Mohsen, so you can see that they already developed transfusion independence and up to 98% on the Casgevy patients. There are also the Bluebird, although it is not approved in Saudi, the Bluebird Bio drug, which is also published recently, the outcomes, which was really showing a sustainable transfusion independence up to 10 years, and you can see those patients, even all different age, pediatric and adult, as well as all the genotypes for the patient. I know there is some patients who are still did not achieve the transfusion independence, but this is also a good result that we have at least 90% of the patient achieved transfusion dependence, and that's why integrated into the TIF guidelines. Any patient who were 18 and above, or even 12 and above, they can be sent for bit-Cell. This guidelines was in 2022. Back then, the Exocel was not approved yet, but probably it will be included in the updated guidelines, and likely to be included as well. The question is, who's going this expensive? So not all patients will be able to afford this treatment. You know, the Exocel is $2.2 million, and the bit-Cell is $2.8 million. That's very expensive, and most of the patients will not be able to afford it. And that's why we really need to have other alternative medications. And here we come to talk about the PKR agonist, the pyruvate kinase agonist, mitapivat and etavopivat. And these two medications are already on clinical, completed clinical trials. The etavopivat is already completed late last year, but it's not published yet. And hopefully we'll hear about the outcome of this phase 2 Gladiolus trial that will show us the outcome of this medication. And that was supposedly to be completed last September. So coming to the mitapivat or pyruvate kinase receptor, we know it's been already approved for pyruvate kinase deficiency patients, and it's been also used for sickle cell disease patients, but now we are focusing on the thalassemia, and here we are talking about both alpha and beta thalassemia. So we are only talking about these two clinical trials, which is the Energize and the Energize T. The the Energize is for non-transfusion dependent thalassemia, and Energize T is for transfusion dependent thalassemia. So what is mitapivat? It is a first-in-class oral small molecule allosteric activator for red blood cell specific form of pyruvate kinase receptors. So we know that the ATP inside the red blood cell is insufficient. That's why these red blood cells get hemolyzed, and that's why the lifespan of the red blood cell will be low. And what exactly mitapivat does, it's activate the pyruvate kinase receptor, so the ATP will get more and decrease the buildup of the 2,3-DPG, and that will lead to increment in the lifespan of the red blood cells. That will lead to improvement in the anemia and also improvement in the ineffective erythropoiesis, and ultimately removing the iron overload and decreasing the iron overload. So what the clinical trial here is the Energize T, where the patient were again randomized into two arms, the mitapivat 100 milligram twice daily, 171 patients, and the placebo arm which was 87 patients, and they were into the double-blind period for 48 weeks, and they allowed to go into mitapivat after the blind period up to 5 years. And the target point or the primary endpoint was to get a transfusion reduction response, and that was defined to be a 50% reduction or more, plus more than or equal to 2 units reduction, and that was the primary endpoint for. There are also secondary endpoints that was in the clinical trial, and you can see here that we have 30.4% of these patients who were on the mitapivat achieved this primary endpoint, which was very successful. Coming to the non-TDT patients, the Energize, so these are the non-transfusion dependent patients. Again, they were randomized 194 patients into 2-to-1 randomization. 130 patients were on the mitapivat 100 milligram BID, while 64 patients were on the placebo arm, and they were followed up to 24 weeks. They were also allowed to go into the open label phase, which was up to 5 years. And it was published with showing very good result as well. You can see the graph here, the increment of the hemoglobin as well as the improvement on the fatigue score for the mitapivat arm. And you can see that mitapivat arm has achieved the endpoint, which was 42% in those patients. Will you dare to compare both Luspatercept and mitapivat? Well, somebody already did and dared to compare both of them, and it was published. Very nice article. Who is interested and read more, I would advise to read this very nice, nicely written review. But in summary, so Luspatercept versus mitapivat, we know that Luspatercept only for beta-thalassemia as of the moment, but it can be also used for myelodysplastic syndrome patients. It is subcutaneous injection every 3 weeks that you need to escalate the dose if needed, while in the mitapivat it's been already approved for pyruvate kinase deficiency and both alpha and beta thalassemia, transfusion dependent and non-transfusion dependent, and there is already ongoing clinical trial for sickle cell disease patient, and hopefully the Rise Up clinical trial will tell us that it is also can be used in sickle cell disease patients. So it is an oral tablet, typically twice daily with a fixed dose, and hopefully we'll hear good news for our patient with sickle cell disease. Whether they can synergize with each other, this is only can be told when we come to the real world data, and hopefully we can use them both together to synergize each other. Looking at the horizon, so what is there is basically that when we look at the cellular therapy, we know it is technically demanding. There is chemotherapy, and there are organ toxicity, the infertility issue, and those patients require to be admitted in order to receive this cellular therapy. And also the cost is very expensive, in addition to the worry that some off-target side effects and long-term safety profile is still unknown. So we have two types of gene therapy. We have the ex vivo, which is the currently approved medication, where this patient is basically harvest the stem cells and then getting the transplant after giving the conditioning chemotherapy. And this is basically what at least concern me and concern the patients. But it is really proven safety and efficacy, but again, the side effects that may happen over the years makes people worried. And the cell processing needs really advanced center, high cost, hospitalization, as well as the toxicity of the conditioning itself. But on the other hand, where an in vivo gene therapy is basically with the use of viral vector or nanoparticles that can be injected directly. So it can be really a simple method, can be a walk-in basis with a low cost, with also off-target delivery much less. And in this situation where we can give it without getting much of worry. So this is the current standard of ex vivo gene therapy. The patient go to the apheresis machine, get the cells to the lab to be bioengineered. Then the patient will be given chemotherapy conditioning, and then the transplant where the patient will be isolated for at least 4 weeks. And that's really what most of the patient doesn't like, to go in that prison or jail for that isolated room. But what we are really hopefully will get in the future is in vivo delivery, where only the LNP, the lipid nanoparticles, can be done in the lab and then can be intravenously injected to the patient as an outpatient setup. So there are a lot of curative strategy landscape going on, and where it is heading, I said already about the ex vivo beta cell and X cell, but we have what is called the base editing to induce hemoglobin F, which is also rapidly advancing. We have the in vivo editor delivery, which is the lipid nanoparticle stem cell transplant, but we have also the epigenetic hemoglobin F induction for those patients. So basically, there is already an a preclinical trial for non-chemo conditioning gene therapies being already studied on animals, and we know these all can be done. So what they give is basically a CD45 antibody drug conjugate. So this is CD45 ADC, and this is showed really a comparable engraftment with also hemoglobin F reactivation. It was similar to TBI and busulfan, and basically what will be is really a paradigm shift or a game changer, where we do not worry about the myeloablation, so there is no worry about the organ of the patient or the toxicity of the chemotherapy, and hopefully we'll get this just simple infusion in the near future, and hopefully in the coming few years we'll hear more about this. And that showed also good result and efficacy in terms of the proven durability and sustained clinical benefits. What about the less invasive and conditioning free? So we do not give conditioning at all, and that's basically the lipid nanoparticles that can be given in those patients where this LNP goes into the cell, and that will produce the editing for intracellularly that will be really hopeful without any worry. It is a non-viral delivery system, eliminates the needs for collecting and mobilization of the stem cells, but it provides a potent and one-time treatment potential for blood disorders such as sickle cell and TDT. The worry is that with the standard LNP, that there might be a trap in the liver that's basically an off-target, but hopefully with the optimized LNP 168, these cells will go directly to the stem cell and the bone marrow itself. So the last but not least, the DMT207, which is a novel hemoglobin F inducer, which is being already studied on preclinical setup, that it is showing really a good result and even better than decitabine. And you can see that decitabine increases the hemoglobin F, but with toxicity, while in the DMT207 is improving the hemoglobin F, but which was safe as well. And that was already showing here. This is basically the spleen of the mice, and you can see the size of the spleen was enlarged with the DMT07. That spleen size has regressed. The take-home messages here are the Luspatercept is really a validated medical disease modifying option that can meaningfully reduce the transfusion burden in both TDT and non-TDT patients, but β-Thalassemia patients, while the pyruvate kinase receptors agonist is really very promising, whether to be used alone or to be added to luspatercept. That's a question to be answered with the clinical practice, and it is used for both alpha and beta thalassemia. We have the gene therapy, which is really approved, and we have more than 90% transfusion independence. We're really promising, but the coming new generation for in vivo delivery or even non-chemotherapy conditioning, that will be showing as of the moment in the preclinical status, and hopefully we'll hear more in the coming few months and years. Thank you very much. With this, I conclude.